Technology Transfer Center. My name is Maureen Fitzgerald. I'll be your moderator today, and our webinar producer today is Veronica Wang. The topic for today's webinar is improving implementation of evidence-based innovations for substance use. And our presenter is Dr. Brian Garner, PhD. I want to tell you a little bit about the Great Lakes Addiction Technology Transfer Center. We're one of the 10 U.S.-based regional and 6 international HIV ATTC centers. We serve 6 states in the Great Lakes region: Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. All of the ATTCs are funded by the Substance Abuse and Mental Health Services Administration. This is actually the second webinar in the Implementation Science webinar series. All of our webinars will be recorded and are being recorded right now, will be available for viewing on the Great Lakes ATTC website along with PowerPoint slides. A couple of things to keep in mind during our webinar. Today's audio will be broadcast through your computer speakers, so please make sure that they are turned on and up. There's no call-in number available. You can use the chat feature throughout the webinar to ask questions and make comments, and we'll also have a Q&A session after Dr. Garner's presentation. About our presenter, Dr. Brian Garner is a PhD, Senior Implementation Research Scientist for RTI International. He's also the lead evaluator for the 2-year State Targeted Response Technical Assistance STRTA project, which is focused on providing technical assistance to help 57 states and territories improve prevention, treatment, and recovery support services for opioid use disorder. In addition, Dr. Garner is the Network Implementation Advisor for the ATTC network. And now I'd like to turn the presentation over to Dr. Garner.
Hi everybody, how's everyone doing today? I know you can't really respond, but I hope you are doing well and hope you can see the slides. I'm looking forward to getting to share some information with you all that I hope will be informative. As Maureen mentioned, the title is, and the focus of this presentation is on improving implementation of evidence-based innovations for substance use. And I tend to use the word innovations rather than practices or treatments. Many people hear of EBTs or EBPs, but innovation is a little bit more of a general term and doesn't have to be specific to a treatment. So that's the reason for using that. And also, this presentation, for folks who've seen me present before, this will be a little bit different. I tend to use animations a lot, so a lot of my slides won't have the animations in them typically, but I hope it will still be a good, enjoyable presentation. This slide here is one of my favorites because it depicts sort of, a picture's worth 1,000 words, and it depicts kind of what's going on. Over on the left are researchers, not implementation researchers, but effectiveness researchers cranking out evidence-based innovations and hoping that they'll be used in practice. And over on the right is the real-world practice where the work is going on. And the bridge is what I think kind of entail or represents implementation research. How do you bridge the gap between research and practice? And the warning sign usually spins because it's for everyone. It's hard work all around. The effectiveness researchers are working hard, and it's not easy. Practice folks are working hard. It's not easy. And implementation research isn't easy either. It's a tough nut to crack, but it is a nut that can be cracked. And in fact, there are some effective and cost-effective implementation strategies that can improve the implementation of EBIs. And I'll be showing at least one of them today and another one that seems to be quite promising. So the last thing I wanted to kind of mention on this slide is that I am an implementation researcher, but I've also done effectiveness and am doing effectiveness research. Have never done practice, but it's the practice folks that I do my work for. I try to think of myself as helping the people who help the people, and so that's why I do the work that I do, and I hope that it can be informative to some of you and the different roles that you play in helping address substance use disorders. So the 3 learning objectives for this presentation are these. The first is just to give an overview of a few what I consider key implementation-related frameworks and models. There's many, many, many out there. I'm only going to be referring to a few, and I'll try to highlight what I think are the key advantages of those models. Second, I'd like to talk about research on implementing the adolescent community reinforcement approach, also known as ACRA. Should probably specify it's mostly on the implementation research side of things. Similarly, research or implementation research on implementing a motivational interviewing-based brief intervention for substance use within HIV service settings. So I hope at the end of our webinar today that you'll have walked away with some information and be informed a little bit further about one or more of these areas. So as far as sticking with the first one about knowledgeable about implementation frameworks, here's one that many people have seen, but perhaps not everyone, and so therefore that's why there is a survey here over to the right that you guys may be able to see. And just real simply wanted folks that are participating today to vote for the extent to which they would say that they're knowledgeable about Proctor and colleagues' conceptual model of implementation research. And that way, as I see the votes come in, I can kind of on the fly adjust kind of what I'll say about this depending on that. So see, I'm actually, I guess surprised, but in a pleasant way that there are several people that are not at all knowledgeable about that. And that's probably because there aren't a lot of, maybe those folks aren't researchers, implementation researchers, and so are, not worried about that stuff. And so therefore, this is a great slide to go over. And I'm losing my ability to do a little cursor that I think I had. I don't know if Maureen or Veronica are able to help get that back. It seems like now that the poll's on there, I can't do the cursor to be the pointer. Can we kind of close out the poll, and then hopefully it'll come back to the meeting? There we go. That's what I needed. If it'll, Is there a way of enabling the pointer that doesn't seem to be working? There we go. Okay, now I got it. Thanks, guys. I'm sorry about the minor technical difficulties. So this is, again, a conceptual model of implementation research. This is a super helpful model for sort of laying out, what is it that an implementation researcher is doing. And what I mean by that is you have over here the intervention strategy, the clinical intervention, the thing that that effectiveness researchers have developed, the thing that we want practice to use. The adolescent community reinforcement approach is an example of an evidence-based treatment that I'll be talking about today, as is motivational interviewing. It's sort of a constant as part of, or at least evidence-based practices are a constant of implementation research. The real focus of implementation research is on the strategies. What's different strategies that can be at one or more different levels, individual providers, consumers, organizational system. What are the different activities that are being done to help implement and ensure quality implementation of the evidence-based practice? And in terms of what we hope to see, Proctor and colleagues, one of their main contributions was distinguishing what they called implementation outcomes from what they called, or from what effectiveness research typically focuses on, which is the client outcomes. And so some of the key implementation outcomes that folks have found to be useful are fidelity, so the quality at which a evidence-based intervention is being delivered. Penetration, the extent to which the percentage of clients that are needing that evidence-based practice are receiving it, or it could also be measured in terms of the number of practitioners at an organization that should be trained in the evidence-based practice that are trained. So those are things that implementation research can try to do, but ultimately they're doing all of this because we're trying to improve client outcomes. So this next slide, again, we'll do a poll here, and luckily my cursor stayed, so that's good. This is a framework by Greg Ahrens and colleagues, and it's commonly referred to as the EPIS framework. The EPIS is an acronym which stands for the exploration phase, preparation phase, implementation phase, and the sustainment phase. This is a really useful model for breaking out this process into different, to these 4 key phases. And implementation research does primarily focus on this 3rd phase, the implementation phase, and is increasingly emphasizing the importance of not just implementing something, but trying to sustain the implementation of that evidence-based practice. And what's really valuable about this model is that it proposes several of the factors that are outer context factors, and I know that these aren't able to be read on this PowerPoint, but we don't have time to go through them either, so I would refer readers to people that are interested in learning more about it to read the article, but it does highlight key outer context and inner context factors that are related, that are key to influencing the implementation phase, key to influencing the sustainment phase, and they're not the same. It also is important because it helps acknowledge that there are phases before implementation. The exploration phase is closely related to dissemination research and how do you best disseminate information to folks and move people from where they know about something and have decided to explore it and learn a little bit more about it to actually make that decision to adopt it and then start preparing for implementation. And so this is where a lot of the training that evidence-based practices go on, that you have to be prepared and trained before you can actually begin implementing with actual clients. So I find this to be a really good framework in terms of laying out it into different phases, as well as what are the factors that are important at each of those phases. And again, they aren't the same, and therefore that's why it's important to distinguish between them. And based on the results of the poll, it also looks like that a lot of people are learning about the EPIS framework, so that's great to hear. It, again, is a pretty simple model that I think does help kind of frame the work that someone's doing. What is the phase that this clinician or this organization is in? A lot can be said about all of these, but keeping them pretty brief for time's sake. So another model, and this is the last one, this is what's referred to as the Effectiveness Implementation Hybrid Framework, and it was developed by Jeff Curran and colleagues. And let's see what we got in terms of folks' familiarity or knowledge with this. All right, starting to, again, have a great audience here in the sense that this webinar can be valuable by informing them of things that they hadn't known before. And for folks who are very knowledgeable about it, hopefully I'll still be able to add some snippets of information that they find valuable too. So the real big contribution of this framework is it helps show the relationship between effectiveness research, what I showed on that first slide, and the bridge, implementation research. And it doesn't really address dissemination research or preparation research or anything like that, and that's okay. But what it does propose is an efficient way to do research, and that's the key, efficiency, at least in my opinion. The key to attribute of hybrid trials are that they're more efficient, because while you're going ahead and doing one research, which the researcher was probably planning on doing, you can go ahead and do some things that would provide value to other aspects. And so what they proposed were 3 different types. The first is what they call hybrid type 1. And here it's really simply just effectiveness research where the primary aim is to determine, is this evidence-based practice and evidence-based practice, is this effective for helping clients? But while doing that, you don't have to just focus on that, has been traditionally done, but better understanding the context for the implementation. Some of those factors that were proposed in the EPIS framework would be particularly important to measure. So that could be done and help inform future efforts. If you go to the complete other side of it, and then we'll come to the middle, the type 3 is the opposite. It's primarily implementation research where you're focused on determining the utility or the effectiveness of an implementation strategy, but you're also focused on looking at its impact on, or looking at assessing clinical outcomes, the client outcomes that are associated with the implementation trial. And then there's the hybrid type 2, where it equally values testing the effectiveness of a clinical intervention while simultaneously testing the effectiveness of an implementation strategy. And one of the studies that I'll be talking about later is a type 2 hybrid trial. And they are not for the faint of heart, I will tell you, but they are, I think, very helpful for advancing the field as quickly and efficiently as possible. So I think they're worth it. Okay, so now that was it. Just there's lots of models and frameworks out there. For the time that we have today, I chose those 3 to provide some information about. I hope that you guys found those to be helpful. Next, we're going to move into talking about some implementation research that was focused on improving implementation of an evidence-based practice for adolescent substance use disorders, and it's called the Adolescent Community Reinforcement Approach, as I mentioned before. It's been around for 20 years, and I would say it has been considered an evidence-based treatment for adolescent substance use disorders for at least 15, if not more, but that's conservatively speaking. And, you know, again, it depends on the audience here and who's there and whether or not you address adolescent substance use, but to the extent that we do have a number of folks who aren't knowledgeable about it, says to me that myself and my colleagues still have work to do in terms of improving the dissemination of information about ACRA so that it becomes, you know, more known, because substance use disorders is an adolescent onset disease, and therefore being able to prevent it and treat it is important. This is one of the most effective and cost-effective treatments that is currently available. And so again, I'm glad to see that some new folks are learning about it and may decide to learn even more about it after the webinar. So because of this practice, ACRA being one of the most effective and cost-effective practices, the Center for Substance Abuse Treatment, which is part of SAMHSA, decided to really promote it and help improve its dissemination and implementation in real-world settings. And have a paper here that colleagues and I, Susan Godley led off this article, and myself and some others wrote up a description of this very large SAMHSA-funded initiative that was essentially called the Assertive Adolescent and Family Treatment Initiative, AAFT. And so we talked about this model for scaling out evidence-based practices, and more information is available there. But for today's purpose, I want to kind of just give a quick overview of it. Again, it was funded by CSAT. For this AAFT initiative, they funded 4 different cohorts of grantees. These were community-based organizations that were going to receive grant funding, $300,000 a year for 3 years in order to learn the ACRA model and then to implement it with clients. And so it was a rather large initiative. In 2006, they funded 15 grantees. In 2007, 17 grantees were funded. 2008 was kind of a bad year, if people remember that and haven't blocked it out, so no grantees were funded. But then things were picked back up in 2009 and 14 more grantees were funded. And then, wow, in 2010, 34 grantees were funded. In addition to these grantees receiving $300,000 a year per year for 3 years to do this, they were also receiving free training and technical assistance to do that as provided by the model developers. So this is great. This is a great way to help improve treatment for substance use disorders, adolescent substance use disorders. Well, in 2007, right kind of in between the funding of the first initiative and the second one, the Institute of Medicine had put out this report entitled Rewarding Provider Performance. And some of the key takeaways from the article, or from the report, it recommended pay for performance, known as P4P, as a promising method to improve the delivery of high-quality care. And it noted that the literature evaluating the effectiveness of pay for performance consisted of fewer than 20 studies, and that they yielded mixed conclusions on overall impact, and therefore more research needed to be done. Using this as sort of the impetus for a research study that could then build on the AAFT initiative, myself and my colleagues put together a application that was submitted to NIAAA, the National Institute on Alcohol Abuse and Alcoholism, and was funded, and it was for a project called the Reinforcing Therapist Performance Experiment. And this is the study protocol paper. Folks could read more about that. I'll share a little bit more here. So in terms of an overview of its aims, design, and targets, if you, again, kind of remember, the AFT is this very large initiative that these organizations were already getting a implementation model. We'll call it the implementation as usual for the study purposes. The RTP experiment, funded by NIAAA, piggybacked on top of this, and it had the aims of examining the effectiveness and the cost effectiveness of providing these monetary incentives, the pay for performance strategy, to therapists as a method to improve treatment service delivery and subsequent treatment outcomes. It was a randomized design, so we randomized organizations and the therapists within their organizations to one of two conditions. The first was the implementation as usual condition, which you could also just think of as the AFT model. And then there was the implementation as usual plus the pay for performance. The only thing we did was, again, offer monetary incentives to therapists as a method to improve treatment service delivery and subsequent treatment outcomes. The things that we reinforced, which are, again, are really critical to a study like this, were quality and quantity. The quality measured in terms of monthly ACRA competence. So the quality with which ACRA was delivered was like one target, and therapists would receive $50 for each month that a random, and that's the key, I think that's a really important part of this, is that a randomly selected, what we call digital session recording, or DSR, had at least one ACRA procedure rated at or above the minimal level of competence required for certification in the model. And so basically, therapists were already expected as part of the project to be recording all their sessions, and we would pick one at random so that we could feel confident about it being generalizable. And if it was rated at or above the level of confidence, they would receive a $50 bonus for that month, and they could do that every month throughout the course of the project. We also reinforced what we call target ACRA. Real quickly, using data from the prior clinical trials that were used to develop ACRA, we were able to derive a target level of ACRA that was very difficult to deliver, even as part of the clinical trials, but when it was delivered to an adolescent, that adolescent had significantly better client outcomes, and so it was difficult but very meaningful. And so when a therapist in this study was able to achieve that, they would receive a $200 bonus, and it would be for each adolescent that they delivered this target level of treatment. So that's the overview of its aims and the design and the targets. In terms of what the study looked like, it was quite large. 29 sites. We only were using the first 2 cohorts of the AAFT initiative. It wasn't cohort 3 and 4, which was constrained just by time constraints and when we were funded. But ultimately, it was a 29-site cluster randomized experiment. Each site had multiple therapists that were participating, and each of those therapists was treating multiple clients. And when it was all said and done, we had a data set that included 986 clients that were nested within 105 therapists, nested within 29 sites. So a pretty large study. In terms of what we found, and if, again, I kind of like to work backwards through these models sometimes, because the ultimate outcome, what we were interested in, was percent of days absence. Again, client outcomes is an important part of effectiveness research, but it's also an important outcome for implementation research. And what we were able to do is, as part of the RTP experiment, is replicate our previous findings, which showed that clients who received target ACRA were significantly more likely to be abstinent 6 months later. So that was great. We were able to confirm what we had found before, but this still is a very meaningful and important target. We were also able to validate the other target that we were reinforcing by showing that therapists who achieved ACRA competence were significantly more likely to deliver target ACRA. That's a really important finding too. But these are just precursors to set up the most important finding of the experiment. What it was truly doing was trying to figure out, could adding pay for performance on top of the implementation as usual be effective? And what we found was, in fact, yes, that therapists assigned to receive these incentives were significantly more likely to deliver ACRA competently on a monthly basis, which is great, which again led to improved target ACRA and better client outcomes. But the biggest effect, maybe because of the fact that the outcome was maybe already perceived to be more clinically valuable, but also maybe because the incentive size was larger, had a very large effect on increasing the receipt of target ACRA by clients. So those are the main effectiveness results. This definitely worked in terms of improving the extent to which ACRA was implemented with clients and had an impact on those clients' outcomes. So very, very glad to see that. So, and that is the take-home message, is that P4P directly improved treatment implementation and it indirectly improved treatment effectiveness. So here is an effective implementation strategy that has at least worked for ACRA and would likely work for other evidence-based practices. In terms of if people wanting more information about that, this is the main findings. They were published in Archives of Pediatric and Adolescent Medicine, and it has more details about the effectiveness results from the RTP study. Actually, also we found that this pay-for-performance approach was not only effective, it was highly cost-effective, and here is a publication on the cost-effectiveness results. I'll go through, for people interested in reading that, which some may, but some may not. I'll just go ahead and dive into the results and give the take-home kind of messages. In terms of cost-effectiveness of the pay-for-performance relative to the existing implementation strategies that were going on in the treatment, here's what we basically found. The bottom line was that in the implementation as usual condition, the total cost, taking into account training and coaching costs, treatment costs, pay for performance, ACRA competence, and target ACRA were not applicable in that part. The mean cost for one of the 15 sites was roughly $63,000. The average cost of all these things in the implementation as usual plus pay for performance condition was roughly $66,000. Only a 5% increase in cost by adding on the pay for performance incentives and the administration costs that are associated with doing that monitoring and delivery of the incentives. So not a great increase in cost, relatively speaking, per organization. Oh wow, this is quite small. I hope it's not this small on your guys' end, but if it is, hopefully I can explain it. So when looking at cost effectiveness, the key thing to look at again is that incremental cost. It was roughly $3,000, 5%, but what is really important is that we found an incremental increase in effectiveness in terms of the increase in effectiveness of ACRE competence, as I shown in the effectiveness findings, was quite large, and it was it was 10. So there was an increase in ACRE competence months of 10 in the pay for performance condition versus those who weren't getting pay for performance, and there was an increase average per organization of 7 additional clients receiving target ACRA when they received pay for performance versus the implementation as usual condition. And when you look at the incremental cost effectiveness ratio, basically how much does it cost for each additional unit of effectiveness, it was only $333 additional for each month of ACRA competence and only $453 for each additional client receiving target ACRA. So the take-home message with this is that an average increase in cost of 5%, roughly $3,000, resulted in a 116% increase in the average number of months that therapists demonstrated competence in this evidence-based practice, and a 325% increase in the average number of patients who received target ACRA. And that also kind of applied equally to the number of days absence per patient because of the relationship being constant between target ACRA and client outcomes. So both of these results taken together, but I mentioned in the beginning, it is tough to implement evidence-based practices, but there are, pay for performance being one of them, effective and cost-effective implementation strategies that organizations or funding agencies can use to improve the implementation of those evidence-based practices. We definitely have evidence that it works for ACRA, and it's likely that it works for other evidence-based practices that are yet to be determined. So that was the second learning objective. Hopefully folks learned some things that might be helpful. The third and last learning objective that we've got today is focused on implementing a motivational interviewing-based brief intervention for substance use within HIV service settings. And the project is called the Substance Abuse Treatment to HIV Care Project, and it's funded by NIDA. We just refer to it as the SAT to HIV project for short. It has just entered year 5. It's 5th and final year, so we've been doing this project for quite a while. It is an important project, in my opinion, because substance use among individuals living with HIV/AIDS is what I call a kind of a double whammy. It is both highly prevalent, much higher prevalence than it is in the general population, and it's highly problematic, even probably more problematic than in the general population because of the fact that increased substance use can lead to increased risky behaviors. Risky behaviors can lead to the spread of HIV and cause new HIV infections. There are about 50,000 new HIV infections in the U.S. every year. The average treatment cost the average lifetime treatment cost of an HIV infection is estimated to be about $400,000. So if there's 50,000 new infections every year at an average lifetime treatment cost of $400,000, that means that every year the United States cost for sort of related costs increases by $20 billion. So definitely a big problem. Something needs to be done. We are trying to be part of a solution for that. And so we have designed this study, which is a type 2 hybrid trial where we were simultaneously testing the effectiveness of a motivational interviewing based brief intervention for substance use, since it hasn't already been established as being effective in these settings, and therefore we couldn't assume it. But we were simultaneously wanting to try to figure out, well, what are the best strategies to get HIV service organizations to adopt and implement this successfully. So that's what I'd like to talk about. I don't think we need the poll on this one. Okay, great. So information about these studies, which I can't explain in the time that we have, can be found further in these open access publications that were published as part of a special issue on HIV and substance use in addiction science and clinical practice. Because of it being a hybrid type 2 study where we're doing 2 experiments in one, we simultaneously published an experiment on both, or published study protocols on both of them. This is one for what we call the MI-BI experiment, and it was focused on testing this MI-based brief intervention for substance use. And in fact, actually, I apologize to Veronica. Let's bring back up the poll. Because it's focused on motivational interviewing. Motivational interviewing is the evidence-based practice. And yeah, so I mean, MI's been around for 3 decades. Everybody has at least some knowledge or very knowledgeable, which is great. It's in contrast to ACRA, obviously, where there were some folks who didn't know about it. MI is a very successful, promising evidence-based practice and was the reason why it was selected to be tested as part of the study. Very promising, but can't assume that it was going to work. So, okay, so in the MI, we could go ahead and take the poll down. This is a figure from that protocol paper, and there's an identical one in the other protocol paper, which I'll show in a second, because we were trying to show how these 2 studies are connected. And so the only difference is that this one is a effectiveness research trial. It's a 39-site randomized clinical trial. So each of these sites participating is participating in a trial. They're helping try to determine, would adding this brief intervention that's based on motivational interviewing, it's just a one-time 20 to 30-minute brief intervention, would adding it to their existing services help improve client outcomes? That's the key question, and it represents effectiveness research, kind of in that research pipeline of effectiveness research to implementation research. The other one is, again, a 39-site implementation experiment. This one I'm not going to expect anybody to be knowledgeable about because this is pretty much all we've reported on. So, but yeah, like what the heck, we'll see about it. This is a evidence-based implementation strategy. So just like pay for performance was our implementation strategy before, now we are looking at something that we call implementation and sustainment facilitation, or ISF. You can think of it as external facilitation, which is that question. So, coaching, having someone that's outside your organization come in and help you and your staff better implement an evidence-based practice is one of the most promising implementation strategies. And myself and a number of implementation researchers have been focused on trying to provide some evidence about its effectiveness and cost effectiveness. So this study could be read more about in this publication. That same figure that I was referring to before is in this one as well, except for that the focus shifts, and that this one is focused on looking at the impact of being assigned to receive the implementation and sustainment facilitation interventions being effective, and this is what's really important for this webinar, above and beyond the implementation as usual condition. And what we picked for this study was the Addiction Technology Transfer Center's state-of-the-art strategy for training staff in motivational interviewing. And it included an online training module, a 2-day in-person training, as well as ongoing coaching and feedback. So it was a quite comprehensive strategy that was serving as our control condition. And while we felt like that was necessary for helping implement MI, it may not be sufficient. And we wanted to test, could adding this external facilitation approach, the ISF intervention, be an effective addition? So that's what we've been doing for quite a while. Here is a flow chart of how the study goes. I think this is one of the best ways to try to explain kind of how this study works. And as I hope some people might recognize, it has the different epiphases that I had shown earlier. It has the exploration phase, preparation phase, implementation phase, and sustainment phase. The way the study worked, in brief, is that we weren't able to work with all 39 organizations at once, so for efficiency's sake, we would work with them in cohorts, as I showed on that first slide. We had the central part of the United States, the western part of the United States, and then the eastern part of the United States. And one cohort at a time, we would recruit organizations for the study. We would then survey them to try to get a sense of where they were in implementing or in addressing brief interventions and other characteristics like their size. And we would use that information to randomly assign them to either get the HTTC strategy that I just mentioned, and I'll mention a little bit more about in just a moment, or the implementation, the HTTC strategy plus the ISF strategy. So they would, without a doubt, get the HTTC strategy, super comprehensive, so everybody was quite excited about participating, and half the organizations would also get this ISF strategy that we were testing. After randomization, the organizations would go through a 6-month preparation phase. We needed to take a slow and steady approach with the organizations. That was at least our opinion, is that slow and steady was going to be the recipe for success. And so it was during this 6 months that the organizations and their staff would complete the 5-week online training, just 1 hour per week. Then they would attend the centralized 2-day in-person motivational interviewing training, and then proceed to practice delivering it and get ongoing coaching and feedback on how well they were doing, with the goal being that at the end of the 6 months, every single person would have demonstrated proficiency in delivering this brief intervention. So that's what we did there. Once that occurred, then there was a 6-month implementation phase. This is where they were completing a randomized clinical trial, and they were actually randomizing their clients to either get the usual care or the usual care plus brief intervention. But we were focused as part of this ISF experiment on seeing if the ISF strategy, which was here, was adding to how effectively the staff and the organizations were able to implement this with clients. And then we also wanted to see whether or not what we did with them would be sustained, and so there was a 6-month sustainment phase, which was all we had time for in the project. As far as what we did, as far as the different strategies that make up the HTC strategy or the ISF strategy, we wanted to try to map to the existing literature, and so Byron Powell and colleagues came up with a great compilation of different implementation strategies, which I know you can't see here real well, but you can find the article. But they categorized implementation strategies into one of 6 main domains. And the first one, and I can hardly read this, but I can go off of memory here, is plan strategies. The second one is what they called educate strategies. The third one is finance strategies. Finance strategy is pay for performance is a great example of a finance strategy. Wow, that one's really small. I think that one's restructure strategies. The fourth one is quality management strategies. And the fifth one is apply to policy context strategies. So the key takeaway is that they operationalized 6 categories of strategies. I think they identified 68 different strategies that are within those, and they operationally defined them. So since they went to all the great work to do that, we decided to map to those. We also decided to specify our HTTC strategy and our ISF strategy in alignment with recommendations that Anola Proctor and colleagues had recommended, which were to addressing a gap that people had not historically been very good at saying what that meant to do external facilitation or whatever strategy they were doing. And so they tried to improve the field by recommending people name it, give it a name, to define it, and then to specify it. Well, the naming it and defining it had already been done quite well on that previous slide by Byron Powell and colleagues. But as far as specifying it, and specifying it according to a number of different dimensions, was a real important contribution of this work. And so they wanted it to be specified in terms of the actor. Who is the person or persons that are delivering the implementation strategy, the action? What is it that that actor is doing? What are the different aspects and actions as part of that implementation strategy? What is who is the action target? Who are the staff, the organizations? Who is it that the actions are intended to impact? Temporality, when does this occur? When do you start doing these actions? Which phase do they begin? Dose is the intensity. When you do start doing this, are you doing this just a little bit, like maybe just for an hour, or are you doing this for 2 days? So again, the dose of the in-person training is 2 days as opposed to just 1 hour. Being able to specify which implementation outcomes are supposed to be impacted. And so this kind of takes us back to that model, that framework we saw where there was different implementation outcomes specified. And then lastly, why are you doing this? What is the justification? What evidence is there thus far to suggest that this is a sound approach? And so this is what my colleagues and I tried to do, which was to be very careful about mapping to the existing literature and make sure that it was very clear and transparent what we were doing as part of the HTC strategy and the ISF strategy. Won't be able to go into that great depth. Definitely will have to refer readers to the articles where they are detailed. And if anything, it's, TMI, too much information, but I don't actually think there is such a thing when it comes to research so that people know what you're doing. But here's the HTTC strategy. It's made up of 10 of the categories that compilation came up with. And centralized technical assistance is kind of the overarching strategy. But the other ones included developing educational materials like the manual, developing and organizing quality monitoring systems, developing tools for quality monitoring like rating sheets, distributing those educational materials, and then conducting educational meetings about them, making the training dynamic, doing audit and providing feedback, which is, and providing ongoing consultation, and creating learning collaboratives where folks can kind of get on coaching calls together and learn about what they're doing. These are 10 categories that represent our 10 implementation strategies that make up what's called the multifaceted implementation strategy for the HTTC network. So it is quite comprehensive. Not every HTTC will do this, have it be this comprehensive. There are even less comprehensive approaches that can be taken. It just depends on what's possible. The key is specifying what was done, and that is what we did here. As far as the additional strategy, the ISF strategy, it included 7 of the discrete strategies that Byron Powell and colleagues named and defined. And the overarching one was this idea of having an improvement or an implementation advisor, like an external facilitator to kind of help make the whole process easier, kind of like a coach or a personal trainer at the gym is how we sometimes equated it. What it also included was, again, developing some tools for quality improvement, organizing implementation team meetings, identifying and preparing champions at the organization, assessing readiness and identifying barriers, conducting local consensus discussions. We particularly focused on our local consensus discussions be around, why do this? How can we sustain this if this does work? Were some of the key things that were done. And then conducting cyclical small tests of change. Many people know that as the plan, do, study, act cycles that keep trying different things at work. This was the crux of the ISF strategy, and these were in addition to the 10 HETC strategies, at least for half of the organizations. So for today's purposes, only have time to present some of our results. So I'm focusing on the extent to which organizations that received the ISF condition, in addition to the HETC, did better than those who only received the HETC approach in terms of this outcome. It's an implementation phase outcome. It's what we call implementation effectiveness. Implementation effectiveness has been defined previously in the literature. It's, I think, one of the most important constructs in the field, and it's defined as the consistency and quality of targeted organizational members' use of a specific innovation. This is how the originators of that construct showed it. The second from the right is implementation effectiveness as this key construct, that the higher the hypothesis is that the greater the evidence-based practice is implemented, the greater it's implemented with consistency and quality, the more likely the evidence-based practice, or the innovation, if you will be effective. And that will be impacted by implementation climate, which is a construct for maybe another webinar, but ultimately by the implementation strategies, the implementation policies and practices like pay for performance or the HETC strategies or ISF, that these things will help improve implementation effectiveness, which will improve client outcomes, how effective the evidence-based practice is. And just to go ahead and make sure not to leave people hanging with these last two ones, that these are all contingent on organizations having the availability of financial resources, which is a very necessary component, but not always sufficient. Having financial resources is necessary, but then also having some management support is important attribute as well. So this is Klein, Kahn, and Sora's framework. It's actually an additional one that I think is really important, and I kind of am sneaking it in here. It guided our work here. So relevant methods for this presentation are this. This is just based on the first two cohorts of data, so the central part of the U.S. and the western part of the U.S. But we had 50 staff from 25 organizations that were randomized to the two different conditions. The outcome was, as I mentioned, implementation effectiveness. It's very specifically operationalized as a continuous measure, staff measure, that represents the sum of the standardized cumulative number of MIBIs, the brief interventions, that were delivered by these BI staff. So consistency and quality are part of it. And from an analytic perspective, we basically did some fancy multi-level regression analysis to just look at the relationship between, hey, which condition were you assigned to, which implementation strategy did you get, and implementation effectiveness. So try to, even though we did some complicated things, it's really to answer a simple question. Does adding ISF help? And so here's what the hypothesized model was, is that basically does having ISF help in terms of implementation effectiveness. You, of course, have to adjust for the many differences that you're going to find in the staff, their age, gender, race, ethnicity, education level, years of experience, average hours worked per week, their prior experience with MI before the project, and their perception of MI, like how well do they think MI fits with their values and the values of their organization. And, drum roll, what we found was it works. Like already with just our first two cohorts of data, we have found that implementation effectiveness is significantly greater among organizations and their staff who received the ISF condition in addition to the HETC model. So the takeaways from this presentation of the ISF findings are three, and this is my last slide, so I think we're doing great on time, is that at least based on our preliminary results, they do provide some evidence supporting the ISF intervention as an effective adjunct to the HETC strategy, at least for this outcome, implementation effectiveness. We've got more work to do to see if it works for other outcomes. The project, each of those cohorts were 18 months long, each of them beginning in January of the respective year. So we are definitely nearing completion of the third and final cohort. It'll be all complete very soon, definitely by the fall of this year. And what I would like to say to folks when I present about this is that, should the ISF intervention's effectiveness be supported, because right now preliminary evidence does suggest that it is, but if we end up finding that this is, when it's all said and done, effective, really think it's going to be important for future research to examine the extent to which these findings can be replicated, because replication is super important, improved upon. Even though I think we've done a really good job, I think that there's significant room for improvement further. And it'd be great to see to what extent these findings generalize to other contexts and evidence-based practice, so other settings and different EVPs. So, but that's what I can say here. So, yeah, well, I'm glad to see some people found it to be very informative. That's what I was striving for. Appreciate that. And I think that's it. Yeah, thank you, and look forward to the time that we still have to have some discussion.
Thanks so much, Brian. We did receive several questions, starting with some questions about the RTP experiment. Are you ready?
Yeah, I'm ready. I just don't see where the questions are at, but yeah, definitely ready.
So the first question about the RTP experiment, implementing adolescent community reinforcement approach, what was the level of therapist years of experience and impact on the ACRA competence?
What was therapist level experience's impact on delivery of it?
Yeah.
I think was the question. So we did look at that, not so much as part of the RTP experiment, but as part of some other research studies that we had. And what we found was that it tended to be that newer therapists that were newer in their position, it wasn't always just about their age, but years of experience in their position. Like if they were hired specifically for this project and they hadn't already been committed to other approaches, that they did a better job of demonstrating competency more quickly than relative to individuals who have maybe been at the organization for a decade or more, really maybe more set in their ways, or whatever. So it's hard to say exactly why it was, but in general, when implementing a new evidence-based practice, there is some evidence to suggest that hiring new staff who will come in and see that as the expectation and the way to proceed might do better because they might be less used to just doing the way things were. So I kind of tend to suggest, that as a very promising way, but it isn't the only way. We had some very seasoned, experienced staff do fantastic. It's just on average, the newer staff that were hired specifically for the project seem to do the best.
Great, thank you. And another question related to that project. Did the coaching trainers receive coaching before providing coaching?
Oh, absolutely. Yeah, there was, I mean, the individuals who were providing the coaching and feedback were ACRA experts, and yeah, and it was quite standardized in terms of what they were providing. So yeah, it was both good and standardized. So it was, I thought it was a fantastic opportunity for us to be able to study pay for performance because of the rigor and standardization that AAFT project provided. It was quite a high bar to go above and beyond, though, when you have so much going on.
Great. Next question is about the ISF strategy. How did you ensure that the ISF strategy was implemented well? Was there variation in how each of the 7 parts were implemented with fidelity? And this is a long question. How would practice settings ensure fidelity of the ISF strategy over time outside of a research setting?
So that's a great question. So what we did in the study was, again, one, standardization was very important, and so there was basically slide decks, and that the ISF coaches would use that would allow them. It was kind of the flexibility, allow them the standardization of going through a same process for each of the organizations. Now, organizations might be in a different phase of readiness or have different levels of climate, and so it allowed to adjust for that. But all the meetings, with the exception of a first in-person or an in-person meeting with the ISF approach, were done virtually, kind of like what we're doing here on this webinar. And so it was an ISF coach speaking to folks on the phone, presenting PowerPoint materials, and just like this webinar is being recorded, the ISF coaching calls were recorded, both the audio and the presentations, and then they could be monitored for ensuring that the ISF coaches were delivering what they were supposed to deliver. And that provided evidence to support what they were documenting in what we called ISF workbooks. ISF workbooks were kind of this Excel-based workbook file that helped document kind of who was attending each of the meetings in terms of the staff, and sort of what were the key takeaways from that, and some of the exercises were documented in that. So we had kind of a combination of a workbook for documenting fidelity, as well as actual recordings of each session. And it was standardized because of the materials that they were doing and what they were focusing on at each session. It was definitely not just having a meeting and then just talking. It was actually quite MI-like, where we were engaging, focusing, evoking, and then planning. So ISF is actually quite a MI-based implementation strategy, if you will.
All right, that's great. And did you also cover ensuring fidelity over time outside of a research setting?
Well, so, since we haven't demonstrated it to be effective, we're still kind of doing efficacy-like effectiveness implementation research. It does seem to be promising. I think more research needs to be done. I think that as far as ensuring it in practice, I think that these are pretty low-cost ways of doing it. I think the ISF workbook is a built-in feature that's just part of the intervention. It helps document it, and doing these or recording it is pretty cheap. As far as monitoring it for fidelity, I think that the biggest approach, the best approach would be having it do random checks. You just don't have the time and resources to listen to every single one, so just randomly checking to make sure that ISF coach is doing what they're expected would be my suggestion, and that's what we've had to do.
Great. We have one more question. And again, this is related to ISS. How can a simulation lab or virtual learning be used to test EVP models? Can they be a method to observe clinical performance and implementation?
Okay, at least I see it on the screen.
Yeah.
How can simulation lab virtual meeting be used to test? That one I don't know. I guess I'd be curious as to what others think on that, because if you're because testing EVP models, that's a little different than I guess the only thing I can think is, and I could be off track in terms of what this person's asking, but simulation lab, virtual learning, testing evidence-based practice models, which I'm going to interpret as the evidence-based practice. I think it's possible. I think that rather than having to use real clients, that being able to do simulation labs or virtual learnings where a clinician who is learning an evidence-based practice is delivering it virtually, and we can be monitoring their degree of fidelity, the quality and competence and adherence to that model is possible. And myself as an implementation researcher would be more interested in figuring out, well, what are the different strategies that are going to help that clinician be the most effective at implementing that evidence-based practice. So, I think it's a lot going on. I don't know if I have a great answer for that one, but, hopefully that was somewhat helpful.
Thanks, Brian. Looks like we've covered all the questions we've received so far. Maybe there's another one coming in. Let's take a look. One of our participants comments that the simulation is used in the medical field. Just wondering about clinical applications, perhaps.
Yeah, I haven't had much experience with that as far as kind of the simulated client or even a virtual. I think it's super promising and exciting because of the fact that to the extent that it can be a good replication of actual practice, or even if it's not, if it can be a way of standardizing the clients, it would help increase the rigor of implementation research, I think, because that is one of the tricky things when we're trying to help individual clinicians deliver a practice. So, man, client severity is part of that, where, implementing a practice is easier or harder depending on how receptive the client is. It takes two to tango, so to speak. And a good clinician can probably do well with easy or hard ones, but a more novice clinician is going to really be thrown for a loop with a really defiant, challenging client. And, it all kind of is, in a large study, you're going to have variation, and it's all going to kind of balance out. But I do really like the idea of virtual simulation labs and how they can be beneficial for teaching evidence-based practices and figuring out what the best implementation strategies are. And I think it's definitely the future. So I'm glad to hear people are thinking that, and really appreciate that question. It's got my mind spinning with ideas about what else to do. So thank you to whoever asked that question.
And we've got a little more clarification from our participant. This is Elaine Wilson. She says clients are used in role play, and clients and actors participate in this kind of simulation.
Gotcha. Well, I know we did that as part of the SAT to HIV project, which again, as a reminder, was simultaneously trying to be an effectiveness research experiment and an implementation research experiment. And we actually did do client role plays as part of the training. At that in-person training, the brief intervention staff that we were trying to train were given scripts. We actually took a lot of time to develop scripts. But what we did, which we thought was really interesting and innovative, was we would pair them up, and we made sure to pair them up with someone from not their organization, probably to make them take it a little bit more serious. But what it allowed them to do is they would each read their complementary part of a scenario, where one would read, okay, I'm supposed to be the client, this is my presenting problem, and this, and then here would be the other one would be the clinician, and they would have just a little bit of information about the client, and then they would try to deliver the brief intervention to the other person and try to do it. And so they'd get a chance to practice being a clinician doing it, which is a role that they were quite comfortable with. But we actually found there to be a lot of value to them also pretending to be the client, because it gave them some insights into the clients and just gave them a different perspective for when it was their turn to deliver. And then when they switched, we also made certain to not just have them do the exact same role play, but we actually changed it up, and it was a different substance or a different age client or whatever. And so they each would have the opportunity to do that at the in-person training, and then we would have discussions about it, and then that was a homework assignment that was sent home to them to do the exact same thing, but this time with their counterpart at their organization, because we trained 2 staff at each organization. So we found the client role-playing to be really helpful, and I guess I wasn't thinking about that when I first read it, but yeah, so I don't know, there's some additional information about how we use that as part of the SAT to HIV project.
Thanks, Brian. And it looks like we might have a couple more questions coming in. You definitely sparked some thinking here, Brian.
Well, good. That's what we like to do.
Yeah. While we're waiting for the other questions, I just want to remind everyone that the recording of the webinar and Dr. Garner's PowerPoint will be available on the Great Lakes ATTC website within the next week or so. And Elaine said, yes, you got it. She was talking about role reversal.
Great. Yeah, I think my brain went to like the kind of computer, like virtual clients.
Yeah.
Which is, that's also a really, that is happening. It's not as prevalent. I think there's a role for that, but I think just typical old role plays and role reversals are, here to stay, especially for psychosocial interventions.
Yes, that definitely seems to be the trend. Well, we're getting close to the end of our presentation, and we'll keep the webinar room open for a few more minutes for any participants that want to chat with each other. As I was saying, the recording and PowerPoint will be on the Great Lakes ATTC website within the next week. And you see Dr. Garner's information up on the slide if you have any questions that you'd like to direct to him directly.
Thanks everybody for making the time to spend an hour or so with us. Really appreciate it, and again, glad to get some good feedback that that people found it informative. So mission accomplished. Thanks.
Thank you for a great presentation today.
My pleasure.